is Dr. Ahlström. Dr. Ahlström is one of the leading embryologists in the Nordic countries and beyond. She has spent a lot of years, many years, yes, at the St. Greska University Hospital. She recently moved to the Livio Research Center, actually IVF Center, where she is a laboratory director. She will give a talk on Blastocyst culture versus cleavage stage. What system gives the higher clinical pregnancy rate? Thank you very much.
Thank you. Yeah, I started my new job on Tuesday, and then I flew to Barcelona, so I feel a bit, I feel a bit guilty today. But yeah, it's a very big pleasure to be here. It's been some lovely talks sort of during this first and second session, so it's been a nice experience. My topic is to look at Blastocyst culture and versus cleavage stage, and to help see which system really we can use to optimize our clinical pregnancy rates. And it's not easy because none of the decisions we make or the clinical strategies we use, in fact, have a black and white solution. We have to consider a lot of different factors that are interrelated and can also affect the outcome. And I'm hoping to show you really in which clinical context Blastocyst may in fact help you optimize your cycle outcomes, and in which clinical context cleavage stage will help you maximize your cycle outcomes. So why are we so excited about Blastocyst transfers? And I think you can look at any national database and pretty much pick out the same data. And I've just taken data from the SART data site. I've looked at single embryo transfer, non-PGT cycles, and after elective set, and their first IVF cycles. And what you can see is that per embryo transfer, Blastocyst will in fact give you a higher live birth rate. It's that simple. And you know, this high live birth rate is consistent throughout the ages. But of course, this is only per embryo transfer. And there's a lot that needs to happen before we get to that stage. And it's not because when we put our embryos in culture, we in fact increase their intrinsic viability by extending them to Blastocyst culture, but it's because, in fact, we're better able to identify those that will in fact produce a live birth with our grading systems. When you look at good embryos on day 3, what we consider good embryos, they still don't reach these live birth rates compared to what we grade on day 5 as embryos of good quality. And we know this is really from expression studies or gene expression studies or developmental studies. It's because at the start of the cleavage stage, development is really driven by a good oocyte. And it's really not until we start seeing it past the 4 to 8 cell stage that the embryo starts to drive its own development. And we start seeing this or observing this in vitro by looking at the embryo and seeing compaction and blastocele development and inner cell mass and trophectoderm grading. And it's at this stage that we really see the potential of what the embryo has to offer and what we can select and transfer back to our patients. But of course, there is a decrease in the potential of embryos, or the decrease in embryos that arrive to this stage in development. Another argument for Blastocyst transfer is the idea, and I think Nick Macklin discussed this a little earlier, is that in fact when we're transferring cleavage stage embryos into the uterus, we're in fact transferring them into an environment which is not nutritionally accommodated to, and they also have a different hormonal environment that's present there straight after this hormonal stimulation compared to the oviduct. And it's thought or postulated, in fact, it's not been proven in the human, that in fact this harms the potential of these cleavage stage embryos. And David Gardner, who's an advocate of Blastocyst transfer, showed this in mice studies in which he took 2 cell embryos, flushed them out of the oviduct, put them into the uterus of pseudopregnant mice, and saw that they had decreased implantation rates compared to blastocysts that were transferred into pseudopregnant uterus. They also had significantly different placental and fetal measurements that considerably were considered to be of a detriment to these fetuses. Did I move? Of course, we're also very aware that what we're really providing in vitro is only the basic needs of the embryo. It's very minimal of this culture system we provide, and it's really not an optimal environment. And we really don't know how many embryos we're losing along the way. It's very hard to determine that if we'd placed that embryo back into the uterus at an earlier stage, that we would have saved this implantation. So we really never know what the losses are occurring during this in vitro or extra 2 days of culture that we're doing. So we always have to be aware of that. What we have been able to show that gives us a great example of this, I guess, is the effect of using non-physiological oxygen tension. And you can see by this meta-analysis, if you look at day 2 transfers on the left, when you culture in non-physiological oxygen, you in fact get no impact, no obvious impact on the implantation potential. When you continue suboptimal culture conditions to the Blastocyst stage, we start to see an effect on the implantation potential of these embryos. So if you're not confident in your culture conditions, then you're probably going to incur a lot of losses. So what sort of clinical data can suggest in which way we should move? Should for all of our patients or for a select subpopulation of patients when it comes to Blastocyst transfer? And I'll look at, there is a whole lot of studies that have looked at cleavage stage versus Blastocyst transfer. I've summarized 4 of the meta-analyses that are published. They've all looked at some of the important endpoints in which we value when we're considering whether or not to move to Blastocyst or whether to stay at cleavage stage transfer. And I've just really summarized what they've come to their conclusions. But I'm only going to focus on the Cochrane and on the most recent meta-analysis that was published last year, and that's mainly because they also graded the quality of the evidence. They didn't just look at the pooled data, they saw if there was heterogeneity in this pooled data or the types of studies, the methodologies they used, and they also looked at the risk of bias in these different studies. When we look at the Cochrane, and Christina showed this previously, what they saw when they looked at clinical pregnancy was a large number of studies. What they concluded was that, in fact, Blastocyst transfer provided a benefit for our patients, and it gave a higher clinical pregnancy rate when compared to the cleavage stage transfers. They also considered this evidence quite of a moderate quality so that we could have some sort of confidence in that this provides an improvement to clinical pregnancy outcome. However, when we look at the live birth data, what we see is that although the Cochrane concluded that we have an improvement in live birth outcome with using Blastocyst transfer, they graded the quality of the evidence quite low and suggested really that a new study, a new randomized control study could come and show quite the opposite effect. And although we can be quite confident that there's some population here that is winning with Blastocyst transfer, these combined pooled data in fact doesn't identify that it's a good concept for all of our patients. Now, just to look at the second meta-analysis, they concluded when they looked at a more limited number of studies, they included only studies in which they looked at embryo transfers that performed both an equal number on day 3 and an equal number on at Blastocyst stage, and they saw no difference in anything. They, in fact, had little confidence in their conclusion either, and they thought that the reason why their results were different to the Cochrane was, in fact, statistical methods that were used in their study compared to the Cochrane, and they questioned the Cochrane's use of a non-fixed effect model. So that was quite interesting, and I think it just shows you the frailty of this evidence and the controversy in really suggesting that Blastocyst transfer is for all of our patients. We can't just pull all the different types of patients and cycle characteristics and think that one strategy will fit all of our patients. So what can we learn from all of these studies? What can we look at? Well, if you look at the sub-analysis and you look at the groups that do benefit or the common denominators, what we can see is that in a lot of patients that were unselected, these are patients that were randomized before or at consultation, before stimulation, or at HCG administration. These patients did not benefit by choosing to do Blastocyst transfer. This wasn't a good stage at which we should be making our decision to extend culture. But in fact, it increased their cancellation rate. It increased the percent of patients that never got an embryo transfer. And at the highest level, there was one study that reported a 27% cancellation rate. So this wasn't a good outcome for our patients. So who did win in this concept? It's those patients that, in fact, were selected. It's those patients where we saw that it looked like we had good development on day 3 or day 2. These have a high developmental potential and will most probably achieve a Blastocyst transfer. And in fact, they did. And those patients had no increase in the cancellation rate compared to the cleavage stage patients. So it's when you select your patients at a reasonable stage, when you know what you have to work with, that in fact you can find a benefit for Blastocyst transfer. There were only 2 randomized controlled trials that looked at poor prognosis patients, and these were defined as patients which had 3 or more IVF failures. They had in fact had quite a good ovarian reserve, so they had a number of oocytes, they had development of embryos, but they did not gain from Blastocyst culture. There was one recent study that not many really, I guess what you would say is use or look at poor responders when we tried to define if we're going to extend to culture or not. But there was one recent clinic that decided to change their clinical strategy. What they did is they had, for over a 2-year period, decided only cleavage stage transfer for our patients. They found that they had a high cancellation rate in these transfers because they didn't have fertilization, didn't have mature oocytes, or they had poor embryo development or arrested development. But they also found that they had a live birth per cycle of 16%, which wasn't too bad for having under 4 oocytes. When we look at day 5, they decided in the next period, we'll change now. We're going to try and see if our patients can benefit of day 5 transfer. And what they found in this population is, in fact, they increased their live birth per cycle, but they had an acceptably high cancellation rate for this patient group. And much of this was explained by arrested development. So I think it's a choice between the clinicians or the laboratory in which policy you would want to encourage in your own clinics. But you can also expect that a high cancellation rate in these patient groups. Next. And I guess, what the Cochrane showed us and the types of patients that will benefit from Blastocyst transfer is in fact backed up by these large retrospective studies that have tried to find how can we identify the population, can we build a predictive model to find who will in fact succeed with Blastocyst transfer, who will succeed with Blastocyst culture. And what comes up most of the time in these studies is that a good maternal age, what is that? That's under 34, under 30. It's not really defined, but the younger you are, the higher chance you have of having Blastocyst development. Also, number of oocytes and number of good quality cleavage stage embryos are also quite often found in these predictive models. And we see one of these predictive models here. You see that with increasing good quality embryos or the average number of blastomeres, you get a higher blastocyst yield and a higher implantation rate for these embryos. When we look at back to the Cochrane or back to these meta-analysis, we also can see from this data is it doesn't matter if you transfer equal numbers of cleavage stage to Blastocyst or more risky of transferring more cleavage stage embryos for these patients. In fact, the live birth rate or the clinical pregnancy rate remained higher for this Blastocyst transfer population. And I think this is very important because we think we can compensate for our poor selection models by increasing the number of embryos to transfer, but it's not actually the case in most situations. There was only really one study that looked at single embryo transfer policy in this meta-analysis or in the group of studies being analysed, and this is Papanicolaou in 2006, an early study, and this is important for how we work really in Sweden because we have such, as Christina mentioned, we have a strict single embryo transfer policy, and we're quite proud of that. We think it's the way to go, the future way to go. But what has helped us and what supports the way we work is the fact that we use a lot of day 5 transfers, and that's because we can still maintain a high ongoing pregnancy and live birth rate for our patients by doing that, and that's supported by this randomized controlled trial. And they also, in these patients, which you could probably, they were randomized before stimulation, but I think you can look at, how many oocytes and how many cryopreserved embryos they have and still see that the cancellation rate was not as high or significantly higher than the day 3 group. So what's left to learn, or can we really trust these studies? I mean, most of them were produced about 10 to 15 years ago, and a lot of things have changed. We've changed the labs, we've changed the way we've worked, we've improved, or we think we've improved, we think we get better. And when you look at the data, most of these have low blastulation rates compared to what we expect today, compared to the Vienna consensus and what we consider as a good rate of blastocyst development. And they also, some of these studies, in fact, the cleavage stage embryos had higher implantation data or higher implantation potential or implantation rates than the blastocysts, which would make me a little suspect, considering all the national data we have today showing consistently that blastocysts, in fact, have higher implantation rates than cleavage stage embryos. And in fact, the newest studies in this Cochrane that have been shown all show a benefit, but they were, of course, most of these were good prognosis patients. And then as Christina showed this, she showed this study that I... But it was very good. She gave me this study, actually, so it was good. So she's already explained it. And, this is the way people are trying to work now. This is the way we want to work. We want to, think that we can have time-lapse systems, a good culture system. We can produce selective models on day 3 that will replace blastocyst and, in fact, give us higher, comparable results. And what this study shows is, it's still unfortunate, but blastocyst transfer using conventional morphology, in fact, still performs better in good prognosis patients. And these are quite good prognosis patients. So what remains to be determined? Well, unfortunately, there isn't many studies on cumulative live birth rates, and we're all very, very dependent on our frozen embryo transfer cycles and how well these perform. And in all of these studies, they showed that you get fewer blastocysts being frozen compared to cleavage stage embryos. You can maximize your utilization rate. But this really isn't worth anything if your efficiency in your cryopreservation protocols aren't at 100%. And I'll show you some examples of how this can, cryopreservation protocols and how well they're working for you on either day 3 or on either day 5 will in fact determine a lot of the times which way we move. Because if you don't recover your embryos from cryopreservation and have higher recovery rates, you're in fact going to move away independent of whether or not you're able to freeze more embryos than another stage of development. And that's right. It was just going to show that David Edgar showed this quite a long time ago. When you look at assessing the effectivity or effectiveness, there's the word, of your cryopreservation protocols, you shouldn't just be looking at whether or not you have a high percent of embryos that in fact have more than 50% blastomeres surviving. In fact, for every blastomere you lose, 1 or 2 blastomeres, you in fact decrease the implantation potential. And many reports report consistently that they accept a 50% survival rate. But in fact, we should increase our standards and report more about how many of the proportion of fully intact embryos we have when reporting about the effectiveness of our cryopreservation protocols. And the same goes for blastocyst recovery. We showed this a while ago, and it's also been shown again recently, is that when you have slow recovery of blastocysts after cryopreservation, they in fact have a lower live birth rate than those that recover quite quickly after 2 hours with re-expansion. So I just want to show some examples of how this can having an ineffective cryopreservation protocol can potentially ruin your cumulative live birth rates or your cumulative or your potential of your cohort. And here is a study in which De Brock did 2-3 years ago, and what they showed is they in fact randomized their patients into they're all day 3 patients, either into a slow freeze protocol or a vitrification protocol. And what they showed is in fact that those patients that came back for frozen embryo transfer cycles after a failed fresh in fact had much lower survival rates, much lower proportion of fully intact embryos. And then when you look at how the downstream effect of this is higher cancellation rates, and a live birth rate per warmed embryo is quite low for this slow protocol compared to using a more effective protocol. So this would be the protocol you'd want to compare to a day 5 protocol to actually give a fair assessment of whether or not it's efficient to have maximized utilization rates. The same applies for Blastocyst. This is a population study that was reported. It's a huge data that has been reported into the Australian and New Zealand database. In fact, what those clinics reporting that they're using the slow freeze method have much lower survival rates, higher cancellation rates, and in fact are not competing with those clinics that are performing with the vitrification protocol. And what you can see is that the clinical pregnancy rate per patient is in fact comparable with the fresh cycles. And this is at a stage where you would consider, you know, when your cryopreservation protocols are performing, or the embryos that you're thawing are performing just as well as your fresh cycles, and this is a stage at which we can really fairly assess when and where should we be freezing our embryos, on day 3 or on day 5. And here's a clinic that would probably be a perfect, is in that sort of perfect situation. They have great survival rates using vitrification for both of their days of transfer. They have high survival rates, fully intact embryos, and you can see that the live birth rate per warmed embryo is quite similar. So if you were to maximize utilization rates, probably in this clinic you would probably get very good results with day 3 transfers, although I can't really, I'm just sort of generalizing here because this study was just a cohort or a retrospective study of their data to see that vitrification was working. One study that did come out 2 years ago was a study from a Brussels group. And when they wanted to compare cumulative live birth rates between day 3 and day 5, and they have in fact achieved with vitrification protocols very good survival rates in both their day 3 and their day 5 group. And what they showed that although day 5, and these patients were in fact at consultation were either told that they would be a day 3 transfer or day 5 transfer. So it's a non-selected population. And what these patients in the day 3 group, in fact, had a lower live birth rate after the first single embryo transfer. But what you see when you look at the cumulative live birth rate, there's absolutely no difference. And in fact, when it's adjusted for confounders, there's still no difference between the cumulative live birth rate between the cleavage stage and the Blastocyst stage. And that's something we would expect when your system's working, when your cryopreservation protocols are in fact working for you. But it's not something that you can expect if you have poor survival rates in one group or the other. So how should we work? I think if some of the stuff in your IVF system isn't working, if you're suboptimal conditions, you don't have a lot of resources when it comes to number of oocytes, number of good quality embryos, then we should always act conservatively for our patients. When it comes to blastocyst culture, we're being more selective, more efficient in our judgment. We think there's going to be a very limited risk for our patients, and the gain will in fact be much better for our patients. But of course, there's always going to be a clinical context in which we need to reflect on when we're thinking about day 3 transfer and blastocyst transfer. When we're looking at advanced maternal age, probably have much lower blastocyst development rates. When we have poor quality, we always try to infer a direct check on day 3, even though we've decided to do day 5 transfer. We always make sure we look at the cleavage stage to really see that development is going as we thought or predicted. I haven't talked about it today, but severe male infertility is also a reason why you would restrict blastocyst transfer in these patients. And when you want to maximize utilization and minimize risk of cancellation, then of course cleavage stage would probably be an option if your cryopreservation protocols are working for you at this stage. For the blastocyst, it's really just helping us select embryos. It's really not providing any benefit whatsoever to the patient or it's producing a better efficiency within our clinic. And so it should be used, but it should be used with respect to what is this clinical context and how well is this patient's cycle performing for us. And of course, we're using it with this single embryo transfer policy. And I'll show the next slide. We also have been using it because we have very good results with our Blastocyst vitrification. So for the Swedish clinical context, when we have a strict single embryo transfer policy, we're not allowed to perform PGS. We are using a lot of freeze-all strategies because I think the doctors are moving over to this without any real consensus, but that's what's going on in our clinics. We have good blastocyst rates when we select patients around about 5 fertilized oocytes. And that's something you work out in your own clinic. You can start high and move your way backwards when you realize that you're limiting the cancellation rate. So it's really not looking about which patients, it can also be looking at what patients you need to protect within your clinics so that they don't have an embryo transfer cancellation. And of course, we moved away from our slow freeze protocol with the Blastocyst because we weren't getting any efficiency in that slow freeze protocol. And we saw that even though we could maximize the number of embryos we froze, we really didn't maximize anything in the recovery of these embryos. And it led to an inefficiency within our clinic. So that's how we work. Thank you.